Yeah, I think it's a good evening for you, I guess.
Yes, yes, it's a good wow 9:30. Oh my, yes, it's a good evening.
Good evening. So it's good morning in our side, and it's a fair talk for having a podcast with me. Thank you.
Yeah, yeah. Thanks for coming on. So
So
what's
it,
going on? How was your day? How was
yeah,
your day yesterday?
so it was good. Lots of cases of pre-dental radiation prophylaxis going on, some biopsies, some developmental odontogenesis cysts management. Yesterday was quite busy.
Right, right. Oh,
So
interesting. What's your favorite thing that you do on a daily basis?
see, my favorite thing since I'm oral medicine, right from my school, right from my BDS, I was most interested in pathogenesis and pathophysiology of the disease rather than the management or the aesthetics itself.
Oh,
So
interesting. Yeah,
I was
yeah,
always interested in the pathogenesis. So that's why I took MDS in oral medicine and maxillofacial radiology. So on the other contrary part, my favorite aspect would be developmental odontogenesis, management of systemic manifestations of, systemic
yeah, yeah.
manifestation. That would be my best aspect. That was the interesting aspect. What about you on the other side?
Surgical procedures. Yeah, a lot of things. Right now, I'm on a rotation where we're doing mostly just extractions of teeth. We do, but actually, we did a biopsy today of a cyst, an impacted maxillary canine. We took the
Mhm.
biopsy out, did an expose and bond for the orthodontics team to pull down over the weeks to come. But yeah, yeah. So, are you doing? You mentioned radiology too. Are you doing mostly biopsies and pathology side, or radiology, or are you doing both?
See, it comprises both. So I can do diagnostic radiology on the maxillofacial aspect and biopsies as well. Incisions and excisions minimal.
Right, right.
So
Ah,
I am
interesting.
mostly interested in diagnostic radiology with CT and CBC.
Yes. Which one do you prefer, CT or CBCT?
Depending on the lesion, if it is excessive, then I will go for CT. Otherwise, CBCT would cover the maxillofacial aspect. 15 into 17 covers the whole skull.
Yeah, yeah, less radiation, right? So
Yes, 10
probably
times less radiation. And this
yeah,
was one of my question in Viva in my MDS final examination. This was the main Viva question. What is the rate of radiations compared to CBCT and CT?
ah. So that was it. That was
Yes, it's 10 times less than CT.
10 times less. Yeah.
Yes.
I didn't realize it was 10 times. I kind of thought it was more than that. 10 times is a lot, though. That is
Yeah,
definitely a
it's
significant.
definitely a significant amount. But on the other contrary aspect, you cannot recommend CBCT for a simple apical periodontitis. It's just useless thing unless you want to know the root morphology.
So Dr. Vamshi and I, we met over LinkedIn.
Yep.
I think you've gotten multiple of my like questions of the day fun,
Yeah.
little quizzes. You've gotten
Yes.
most of them first person correct.
Yes. Yes. That's correct.
Yeah, yeah. What's so funny is that sometimes that's really hard to get because sometimes I've actually had the same. I've had two people answer the correct question within 1 minute of each other, so I can't tell who did which is crazy because I just randomly put out a question. Man, you know what I appreciate most too when you put like a little explanation or a couple details because what I do is I explain on the podcast and then I bring everyone's comment that's more than just like whatever the correct answer is. It's like oh, that's because this and this and this age group and predilection for male or female, and those details really bring a lot into the podcast. And then I always mention whoever said that on
Yes.
LinkedIn,
Yes.
and it makes it such an educational discussion. I love that stuff. That's
Yeah,
what it's all about.
that's correct. But the irony of the thing is, some amount of the population of the dentist or the medical field are interested in the actual pathogens itself because most of the times the actual population diverts towards the aesthetics.
That's right. That's right. That's a good thing. Yeah, that's true.
And nowadays, anterior aesthetics or it's maybe veneers or smile designing. It's on more people are more interested in that.
Right, the visual, the cosmetic.
Yes,
Yeah.
but what I feel the cosmetic, it's like a double-edged sword, right? Even a minute error can destroy the whole treatment process.
Right. Yeah. Yeah. And then people the pathology, it's like it only becomes important to you when you have it, right?
Yeah.
You get the carcinoma, you get the cyst.
Yes.
So yeah, it's very selective.
Yeah. And I find pathology as the basic building block of medicine. You may accept it or not, but that's the truth. Those are the basic subjects. It might be the anatomy, physiology, biochemistry, microbiology, pathology, and pharmacology. are the building blocks of medicine. So it is one of the important aspect where you have to have a minimum knowledge about it. So
Right.
I
Right.
have a couple of questions for you. So, since you are on the other hemisphere of the world, how many cases do you encounter with the oral potentially malignant epithelial disorders?
Epithelials. Oh, they're so. It also depends on our. Well, first of all, that's funny you mention that because it's 9:30 here. It's 8 at night here. It's 8:30 in the morning, little 8:45 now in the morning there. So that is pretty cool that we're having this conversation.
Yes.
Different sides of the world, different times of day. But our institution do we actually do malignant cancers here. There are many oral surgery, oral maxillofacial surgery residencies and programs throughout the United States that only do benign. But
Hmm.
our residency here, we're not unique because there are plenty in the area, but ours does both. So fairly often. I mean, I've done several, maybe a dozen cases in the last 6 months with probably about a dozen cases in the last 6 months of a lot of malignant, a lot of squamous cell carcinoma,
Hmm.
actually, because we have attendings that have
Yes.
fellowship training in those
Yes.
areas.
Yes. So, what about pre-malignant lesions? So, how often do you encounter there? Because here it is every alternative case is having potentially malignant lesions or conditions.
That's a good question. We do. I don't know if I could say more or less. That's a good question. I don't know.
Because I started giving intralesional injections in oral submucous fibrosis patients right from my internship. So
Mm,
you can see, so due to the tobacco dependency and erica nut usage, so we can experience lot of cases of oral submucous fibrosis and leukoplakia as well.
yeah, yeah. Huh. Wait. Yeah. Are you asking me that, or you're saying?
I'm saying to myself,
Yeah, yeah. I was gonna say, yeah. Huh. Huh. There was someone today. I figured I'd run this. Have you seen this? We had a patient today who, after receiving the Johnson and Johnson COVID vaccine,
hmm,
had started to experience lichen planus inside the oral mucosa. I've never heard of that or seen that before. Have
see,
you seen that in
uh,
your?
if there's one critical listing, if it's bilateral, it's lichen planus. It's unilateral, it's lichenoid reaction, right? So drug-induced lichenoid reactions I have seen. So we have to first get confirmatory whether it is lichen planus or lichenoid reaction.
Right, right. They've been diagnosed for years. It
Yeah,
was lichen planus. Yeah,
yeah. So if it is drug-induced lichen planus as well, we need a confirmatory biopsy, and we need to rule out all the possible drugs if whatever he has taken apart from this vaccine, Johnson and Johnson vaccine, what you have mentioned.
yeah.
So
I
it's
don't remember.
so
Yeah,
what is the typical symptoms? It's burning sensation or is he's seeing a lacy pattern on his mucosa?
both. They were saying extremely painful. Yeah.
Then it might be drug-induced lichen planus, which is very rare. I did not encounter drug-induced lichen planus as of today. I have encountered due to stress and hormonal changes mostly, and especially in females. But I have seen typical lichen planus in males with Gardner, with syndromes, with
Ah,
diabetes, lichen planus, and hypertension. Greenspan syndrome,
interesting.
what we call, right? Greenspan syndrome. I hope you remember that. So
Yeah,
I
yeah,
have
yeah.
seen in male patients who are having diabetes and oral hypertension in association with oral lichen planus.
It's crazy, and I believe this with this patient, for example, that it was medication induced. Yeah,
Mm.
which is really sad because you go from all of a sudden having an autoimmune disorder. Yeah, hormonal changes. I've seen it. Oh no, that was mucous membrane pemphigoid. That was a different patient. This is
Yes.
a couple weeks. This is a month ago. Like the hormonal changes around
Hmm.
50, 55.
That's good. So you have seen the symbol pharaon in the eyes and everything, the typical
Yes.
scarring and everything.
Yep.
That's good. That's good. I always wanted to see a patient of xeroderma pigmentosum, but I never saw in our region. I never had the
Oh,
chance.
really?
Yep.
Huh. I don't think I have either.
It's like two in every population you get that. So that's a crazy case. Day before yesterday we had a case of malignancy involving the left fascial pillar. Patient had no history of habits though. So we did P16 and P16 came as positive. Ultimately, it is HPV which was causing the oropharyngeal carcinomas right now.
Wow. Wow. Is that wait, so it tested positive for P63 and but you were saying did it have characteristic clinically did it look like cancer?
Yes, we did a
Yeah.
biopsy. It came out as moderately differentiated squamous cell carcinoma.
Oh, so it did. Oh, okay. Oof.
So right now the tumor is extending from the left fascial pillar and it has invaded the left pterygomandibular space. So
Ah.
there is restriction of the oral, in the oral cavity. We have to do emergency extraction of forate because it was we found out it had caries involving the distal pulp horn. But the problem is
Mm.
the caries was below the gingival margin, which was non-restorable. So we had to do a surgical extraction.
Interesting. How many years have you been working in everything? Everything that. How many
Mm,
years? When did you
right.
start school?
See, I've started my BDS. We do BDS, you do DDS. That's a Western
Yeah.
Commonwealth. So I started my BDS when I was 19 years. I have completed it when I was 24. It's 5 years. Next,
Right.
1 year for the preparation for the masters. So after that, I've taken my PG around 27, and I've completed. Sorry, 25, and I've completed in 28.
Oh, so you worked for 2 years, and then 25 to 28. That's when you did the
Yes,
master's area.
yes,
Okay, and so it's 3 years to specialize.
yes. In
Oh
India,
wow,
it
wow,
is
wow.
3 years, 3 years course. So we have same, my prosthodontics, periodontics, oral and maxillofacial surgery, oral medicine and radiology, oral pathology, public health dentistry. Same. Both the aspects are same.
Did you say pediatric dentistry and periodontics,
No,
or
no.
to the
Periodontics is it's a separate specialty, and pediatric and preventive dentistry is a separate specialty.
pediatric and preventative?
Yes.
Oh, interesting. They combine that into
Yeah,
one.
actually, there is something called as public health dentistry also, which does the mass fluoridation programs and everything. That's a different specialty as well.
Wow, no, I didn't realize that. I wasn't familiar. Do you have anesthesia as a separate part of dentistry too near you, or is that
Yeah,
something else?
it's like it's one general anesthesia or the our common local anesthesia aspect are we talking about?
General anesthesia, like
General
IV
anesthesia,
sedation. Yeah.
yeah, we study that, okay. But if you go into sedation dentistry, that generally pediatric dentistry, those prefer those cautious sedation and everything. They learn much more than us.
Yeah. Yeah.
As a
Yeah.
subject, we learn about the pharmacology, pharmacokinetics, all the aspects of general anesthesia. But coming to actual this thing, oral surgeons and pediatric dentists, they learn more.
Okay. So oral surgeons and pediatricians, they can administer anesthesia,
Yes,
maybe not general anesthesia, but IV sedation.
yes.
Yeah. Okay. Similar here to
Mm.
to an extent. Oh, interesting. Yeah. 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 Wow. How far away do you work? Where you live?
It's around 2.5 kilometers. I have a metro. I commute, go and commute.
Oh, that's fast. What is that? 10 minutes? 15 minutes?
Yeah, 10, 15 minutes, it's fine.
Yeah. That's pretty good. That's not bad at all. That's a small commute.
Yep.
Do you have kids? Are you married?
Oh, yeah, I'm married for successfully 3 years. I have a kid who is 6 months old.
6 months. Congratulations.
Thank you so much. And what about you on the other side?
Hopefully a wife someday. Not yet.
That's good. That's good because recently
Hopefully.
one of my senior who has completed BDS here has came migrated to USA. He got admission into Philadelphia School of Dentistry, I guess.
Pennsylvania?
Yes, I hope so. I don't remember the correct this thing. He has completed his NBDE, then he has completed his DDS as well. Right now he is working as a dentist in USA itself.
Excellent.
That's good.
Excellent. Yeah, there are two dental schools in Pennsylvania. That's one of them.
Hmm.
Excellent dental school. Yeah. And
So
he worked with you there where you are?
yeah, he was my super senior in BDS.
Oh, super senior. Okay, so he was above you.
Yes, 2 years
Do you, do
above
you
me.
think you'll come to work in the United States? You'll follow in his footsteps?
Let us see if God's a will, if there is a will, let us see. I
Well,
was more interested in research aspect. I want to explore the concept of oral biology and rule out oral genomics. So let us see. I have a plan. Let us see if it works.
oh, I like that. That's a big bright endeavor. I like that a lot. That would be excellent.
Because oral biology is one underrated aspect where you need to have complete understanding. So I
Yeah,
want to explore that aspect as well.
100%. I agree. I definitely agree.
So, how many cases of leaf out are you experiencing every day? Leaf outs and mandibular fractures, whatever it is.
Gotcha, gotcha. Right now I'm in my final year of residency, and we have three rotations. Three. Right now I'm at the dental school, so no fractures, no big Lafort surgeries. We focus on extractions, exposed and bond, dental clinic stuff, IV sedations, putting patients to sleep, working with the orthodontics and stuff. The next rotation I'll be at it's like 2 months, 2 months, 2 months, and then we
Mm-hmm.
do it again. So right now it's 2 months, and then the other two are both in the hospitals. So that's when we'll be getting the mandible fractures. We'll be getting the all facial fractures. That's when we'll be planning orthognathic surgery, the
Nice.
Laforts,
Panfacial
the
trauma, right?
yes, correct. Now those don't come in as much. My last 2 month rotation, we didn't get any panfacial trauma. So
Mm-hmm.
it's variable, and it's seasonal too. In the summer, when people are getting in the middle of the summer, it gets very hot out, everyone's outside,
Yeah.
everyone's on a bicycle, everyone's in a car. There's a lot of trauma. So it in the middle of winter when it's snowing out, not much trauma. It's freezing outside. It's
Yes.
raining maybe, When it rains, the trauma's less generally. Yeah.
So it's
So it's
like
interesting.
if it for us, winter season is like jackpot because we expect a lot of viral infections. Herpetic stomatitis, herpes labialis, herpes zoster. So actually, we oral medicine people like winter season.
That's funny. So it's
Yeah,
opposite.
yeah, it's quite opposite because you see varied cases of herpetic presentations. So it's like
Yeah.
we can see classical herpetic vesicles, healing blisters. Classical textbook dermatable fashion of herpetic zosters. So
Why do you think that's it's opposite in the winter?
due to the activation of the virus, I guess, due to stress and activation of the virus, you can see all these
Ah.
cases. Because right now we are going into the summer, but last up to the December we saw varied cases of herpetic gingival stomatitis, primary herpetic gingival stomatitis as well.
How about that? But your winter is because you're on the opposite side, right? So your winter's hotter weather.
Yeah, it's not hotter weather. It's not extreme cold as well. So maximum the temperature would get down to 19 degrees centigrade or 20 degrees centigrade, not below the freezing point as yours.
Right, right. Oh, okay. That's not too cold at
Hmm.
all. Today was 9 degrees in the morning, so
Mm-hmm.
9 degrees would be like negative 5, 10 Celsius,
Wow,
maybe. It
it,
was
it,
pretty
it is
cold.
below the freezing point. It's pretty cold, right?
Oh, it was so cold today. It was
Okay.
so cold.
So when is your oncology rotation coming up then?
On call? Actually, yeah. This I have 3 weeks left of my one rotate, 2 months rotate of not being on call. So the next rotation, I'll be on call, second call. So I get this year. I get phone calls rather than actually having to go into the
Yes.
hospital. I've had to go in 2 or 3 times, but it's much better this year. I just take phone calls. So the next 4 months, starting in 3 weeks from now, for 4 straight months, I'll be on second call every single night of the week and 1 to 2 weekends a month. I'm
Oh,
on call this coming weekend. Not as much. Neither of those. I'm not doing too. A little bit of Botox. Not much fillers. A brief introduction to it. Not as much. No.
because in our side, oral surgeons within their curriculum they have this hair transplantations, earlobe repairs, and everything.
I know. Yeah. Yeah. They're really kind of branching into different territories. The one thing you have to be careful with hair transplants, yes, some are doing it, but it's very political in the northeast side of the United States. So there's only so much aesthetics, and you really have to have extensive training in it
Yes.
because if you have an average amount, the plastic surgery or the ENT surgeons could say you're not trained enough to do this,
Yes.
and it's a lawsuit, and then you could get your license taken away. Yeah.
Yeah, it's the same, and nevertheless, it's almost the same here between the dermatologists and oral surgeons, which is going on.
With the hair transplants, right?
Yes, yes. So it happens, multidisciplinary approach. They are just branching out. So these things happens whenever they are trying to branch out.
Yeah. Yeah.
So what about dental implants or pterygoid implants or zygomatic implants? So what is your take on that?
I like all on X implant. I like implants. I like implants a lot. The one thing is that the bigger implant cases, it's kind of like the branching out of oral surgeons into doing hair implants and stuff. You have certain general dental or other dental specialists branching out into big procedure areas. The zygomatic implants, pterygoid implants.
Yes,
Now, if you place it correctly, you could get it right in basically the maxillary tuberosity, and you just barely kind of getting into the pterygoids. But anywhere further posterior than that, you're getting into an area of a lot of anatomy, a
yes.
lot of critical structures. You know,
Pterygoid plexus of veins. So
and you
what?
don't learn any of that in a regular dental resident. You get it. You know anatomy, right? You have to know everything.
Yes.
But so it's very interesting, but there's also no accountability. There's no one kind of going through and checking, why did this problem happen? Oh, well, it's a dentist who's not trained to do that, and they did it because they want this or that. No, it's very interesting. In oral surgery, we're very well trained
Yes.
in pretty much anything in the face.
Because
So yeah, the implants are fun.
recently I was going through an article where they have placed the implant right from the bregma to the implant where to support the maxillary denture.
Right, the
No,
midline. Right? Yeah.
yes, towards the middle. And I was just shocked, where from the anterior cranial fossa we are getting the support. But what happens if we break the anterior cranial fossa? There will be CS, So how
Yeah.
to manage that? What is the intriguing in this? CSF rhinuria if it comes due to the implant which is
Right.
placed in the anterior cranial fossa. So how to manage that?
I think the best thing I would say is just prevent it. I wouldn't do something like that because there's a lot of complications you could have, How to manage that? Oh, I mean, that would be, you need to consult. You might potentially need to consult a neurosurgeon, and you're
Yes.
going to get in a lot of trouble for doing that.
So, what are the odds of you as a oral and maxillofacial surgeon treating a craniofacial disjunction or Lefort 3 fractures?
Lefort 3, I haven't done any myself. I believe, yeah, we have had that in our residency. We did a Lefort 2. Yeah, we're trained to manage that.
Because it's almost intriguing that you are handling the anterior and middle cranial fossa as well because it's craniofacial disjunction. So
Right.
that's why. That's good. That's good. Nice to hear. And even here they do the same. Almost. That's good.
Yeah, it's so interesting. I mean, I think the biggest thing is preventative, just to try and prevent things from happening. That's the biggest thing.
Yes, always there's the take prevention is better than cure. I'm always in that. You know,
That's right.
on the other hand, how many cases of salivary gland tumors have you experienced in the total residency of yours?
For me, just a handful. Pleomorphic adenomas. Let's see, what else do we? I think there was an acinic cell carcinoma. We've had numerous squamous cell carcinoma, but that wasn't specifically to the glands. Yeah, not as much as just epithelial.
Recently, we have encountered a case of adenocarcinoma of the parotids, right parotid.
Oh, of the parotid, yeah.
Yes, right parotid. So initially, we have to refer the case to the oncology hospital.
Oh man, yeah, right. You'd have to do that. How often have you seen that?
In the oral cavity, I've seen many cases involving the gingival buccal sulcus or the alveolus itself or the maxillary sinus or the right and left buccal mucosas. Out of 10, one case I see of parotids, which is very rare.
Yeah. What do you see most often in your area?
Oral cavity, common carcinomas involving the right buccal mucosas or gingival buccal sulcus. It is either exophytic in growth or endophytic in growth. I
What's your
have
favorite?
My favorite is always exophytic growth. It's easy to access.
Yep.
Endophytic growth, it burrows itself. So getting a perfect sample is a difficult thing
Right.
because there
Huh.
is always a risk of bleeding from the side. So the best thing is exophytic growth itself.
That makes sense. Yeah. Do you like to take it to the lab and look under microscopes and
Yes,
stuff, or
yeah, I personally call the pathologist or the oral pathologist, madam, or I want to see the keratin pearls breaking basement membrane. I want to see the dysplastic cells. So they send me the slide pictures in 10x, 45x, and 100x.
yeah.
They don't allow me in the processing part because it's their professional this thing. So they don't allow me in the tissue processing part, but they allow me to visualize the slide pictures.
I didn't think about that.
They teach me. We have knowledge. You can get it from anywhere. Anyone can teach you. So they
Right.
tell me this is the cell, so we can give it as this. So in my experience, total, I did not see any case of poorly differentiated squamous cell carcinoma. I have seen well differentiated and moderately differentiated. What
Right.
about you on the other side?
As far as which one?
Poorly differentiated squamous cell carcinomas.
Just in residency, I haven't seen too much of an array between the. I don't know. I think that would be a better question for my attending, for my boss. Yeah, I wouldn't be able to let you know. Yeah.
So, is oral oncology posting is also part of your residency?
On posting where?
Or in
On LinkedIn?
oncology, in onco hospitals, cancer
Yeah.
hospitals?
Well, we don't look under the microscopes. We don't get into the pathology lab, although I do believe that would be very beneficial to our experiences. It's really just the diagnosing biopsy, explaining to the patient, working up for surgery,
Surgical
and
part,
then post.
you go into the surgical resection part as well, because our side they are posted into the cancer hospital where they have to learn the resection and reconstruction part. They will be posted for 1 month,
Yes, yes,
so you learn that as well.
we do. We don't learn it to the extent we could do it after residency, but we learn it. We get exposed to it. We assist. Sometimes we do the resections,
Yeah.
the surgery itself.
So even in
Um,
our side on the oral medicine aspect, we get posted in 1 month, 1 month in oncology hospital where we do medical, where we learn radiation oncology, which is important for us, and the medical oncology we learn. The surgical oncology we know we learn to the extent of dissection. So MRND 1, 2, 3, what is elective, selective. We learn
yes,
that, but our most concentration would be on radical RT or chemo or medical oncology part. You know, management of post-radiation mucositis, management of post-radiation xerostomia, management of post-radiation candidiasis. That would be our interesting part.
right. I want to change direction. I'm curious. What do you do for fun outside of work? What do you
Outs-
do for
Outside of work,
what hobbies?
I am a foodie. That's the first and primary aspect. Second thing, I play badminton.
Oh, badminton.
Yeah,
Yeah, yeah, yeah.
badminton.
Badminton's a lot of fun.
Yeah, badminton with friends. Third thing, I'm a family guy, so I enjoy with the family having, when it comes to weekends, come early, finish your work early, put on a movie and enjoy with the family.
Yeah. Oh, that's great. You get everyone over to one house. Have
Yeah,
you go to visit someone? How does?
no, no,
Okay, okay.
in our house only. So it's like, my mom, my father, my in-laws, my wife, my kid, me. So we put on a movie, have a dinner, and enjoy the weekend. So what about you?
I like to do social media content for one.
I
I
see,
like to
I see that every
use
alternative day.
devices. It's so important. It really is. Yeah. I like exercise. I like spending time with family and friends. I agree with you. I think it's so important. It's probably the most important thing is your family, and your friends. What did you say was number one again? I didn't hear that part. It cut out.
Foodie. I am number one foodie. I like to eat food.
Food. What's your favorite? Do you cook?
Yes, sometimes
What's your favorite meal to have? And can you cook it?
it would be like chicken biryani. I think you have eaten it in some time.
I'm sure I have. I have hard recognition of certain food dishes with like what it looks like, but I've had a ton of.
Have you ever tried Indian dish? Indian cuisine.
Yes, many times, many times. I just the names, it's tough, yeah.
So it's chicken biryani is my favorite, and next one is you know KFC fried chicken. That's the favorite part.
Really? The best.
Yeah, that's the best.
Excellent. Chicken biryani. You'll have to let me know that one because next time I get Indian cuisine. I live on First Avenue in Manhattan right now, and two avenues over we have a strip of several blocks, and it's all Indian cuisine. Some of the best in New York.
That's good.
So I'll have to try that cuisine, that you the specific dish, chicken biryani. I gotta
Chicken
I gotta get
biryani.
that one.
So that's good actually. You get in lamb and you get in chicken. It's up to your savory is what you want. It's up to your taste buds.
I'm gonna have to do half and half. I think I want both.
That's good then. That's
Yeah,
good. That's good.
yeah. Oh,
That's good.
interesting.
So that's the thing.
Oh, very cool. Yeah. What was that?
So that's the thing. So it's up to you. It's up to your taste buds what you want to eat.
Yeah. I don't cook, so I'm a big fan of getting food from other
So
places.
you're a food fan of takeouts. Good fan of takeouts then.
I am a fan of takeout. I try and save money though. I go to like the grocery store and I'll get like the salad, I'll get the pre-made chicken and just throw some dressing on it. Just something simple. I don't know.
That's good.
Yeah. But all right, Dr. Vamshi. Well, I have to go get ready for tomorrow now
Yeah.
because it's getting to be closer to midnight. But
Me.
thanks for coming on today.
Yeah.
Thanks for chatting.
Thanks to you. Thanks to you personally, because it's very rare to get a podcast like this
Oh, yeah. You mean like late at night or?
late at night and having a conversation with a specific doctor who's on the other hemisphere. You know, it's
Isn't that amazing? I think that's so cool. That's
it's
great.
good. It's great. And thank you for giving me this opportunity, Dr. Brandon. It's good.
Of course. And you're going into work now?
Yeah, I have to go to work. I have a full mouth rehab. I have a case of biopsy for Lichen Planus, so it's full up.
You got a busy day. Okay.
Yeah,
Okay.
because
All right, Dr. Vamshi. Well,
one case has a indirect sinus lift, the other case has a biopsy in the retromolar trigone. So I'll be in company with the oral surgeon.
Right, right. The retromolar trigone. That could be. Hopefully, it's not what many times it is.
Yeah,
You
sure.
know.
Chala, that's
All
good
right,
then.
Dr.
All
Vamshi.
right.
We'll
Have a
talk.
good day.
We'll talk soon. Thanks for
Sure.
coming on.
Thank you. And share me the
All
link
right.
once the editing is done.
Yep. Yeah, you got it. You got it. Remind me. Remind me.
Sure.
Okay.
Have a
All right.
good
Have a
day.
good day.